too much.
Yeah.
Cheers.
Well, it's come time. It's a final day, final session. How are we all? Oh, you sound happier today than you did on Tuesday. What a week. We've really been able to cover a lot. We've had some great feedback from the workshops, both the wound care one yesterday and the ECG one today. Good news for those looking to come back next year when missed out on any of those workshops. We're looking at putting on a second wound care workshop, probably focusing on suturing, and then hopefully we can get the guys back again as well to do the ECG fundamentals, but then also a second part 2, I guess, or work on after that one. So if you are looking ahead to next year, get excited. I think 13th of October is our start date for that one. But yeah, they're been great to test those workshops, and thank you for everyone who's come along to those ones. Today, we've got 4 presentations for you, so it's a bit of a strap yourself in and enjoy the ride. We're just trying to work through a few IT difficulties with one of those presentations, so it's a fluid timetable at the moment. We may have a break after this first presentation, we may not, so get excited about that. Yeah. That's it for me for now. I'll give you guys a bit more info as the afternoon progresses. Don't forget 7:30 tonight at Damaria. It is about 2 kilometres away, so if you do need any assistance in getting transport there, we do have a shuttle bus running through Locum Life. Otherwise, there's plenty of ways to get there yourself. Walking, Bluebird, Gojek, or anyone down the hotel lobby will be able to help you out. From here, I'd say give yourselves probably about 20 minutes to get there because the traffic, as we all know. Let me just bring up our presentation, and as I do, let's give a warm welcome to Rachel, our first presenter.
Fantastic. Thank you so much, Quentin, for that introduction. Hello, everybody, and welcome to the last day of EMS in Bali. Bali's beautiful. It's what I call my second home because I do live here in Canggu, so I get the privilege of being amongst these beautiful people. So thank you so much for having me today. My name is Dr. Rachel Wardrop, and I'm presenting to you today my program of research that I completed last year, actually, which essentially is people brought in by police to the emergency department. Now, Scary. We're good. Out of curiosity, I know we are all ED based, somehow, somewhere connected. Who has dealt with a patient brought in by police? Yeah. Do you think they are inherently complex? All the hands stay up in the air, absolutely. So that was one of my motivators for undertaking this program of research. So bear with me, I'm going to step you through each phase today. I hope you find it interesting as I do. It is definitely a passion project of mine. Just a few definitions. I know you're all clinicians, you're super familiar with most of these, but I do like to speak in acronyms as any clinician does, really. ED, brought in by police, BIBP, brought in by ambulance, and privately arranged transport are the ones that I use quite a lot. Everything else like length of stay, mental health, probably makes sense to you. So, as we know, ED presentations, massive, right? We see them grow every single year, not just in Australia, but overseas, of course. They do represent, yes, an ever-growing demographic, but they are complex in themselves, aren't they? So even between 2019 and 2021, they increased by 6.9%. On average, we're seeing an increase of about 3.2% per year. In Australia, rough estimates are about 8.8 million. Seems like a lot. It's a drop in the ocean, though, compared to everywhere else. The UK, 25 million. And the US, because they like to be big, 130. So within this niche, within these particular presenters, we have people who are brought in by police. Okay, so 2020 to 2021, they were about 0.6%. Most recent figures indicate a whole 0.1% increase. However, as you identified before, they are inherently complex. Okay, so this is people arriving with police and correctional services vehicle. So they can arrive from short-term custodial settings or longer-term settings such as prisons. What we know prior to undertaking this program of research is they're more likely to be between the ages of 18 to 54, and about 71% have a mental health related condition, which is phenomenal. They're also more likely to have an involuntary assessment order compared to any other mode of arrival. So we're all probably familiar with what that means, but basically it's the ability to detain and transport somebody to a place of safety for assessment. And of course, the legislation varies by state. In Queensland, which is what I'll be speaking to because my figures are from Queensland, we refer to it as an emergency examination authority. They're also considered to be vulnerable. So what makes people brought in by police vulnerable? A few different things. We found high levels of unemployment, unstable housing conditions, and high levels of mental illness. But being in the ED, as we know, further complicates this. There's a power imbalance between the patient and physician. Staffing opinions of mental illness, the fragmented care that often occurs in the ED, being transported from one location to another for testing, etc., and the often chaotic nature of the ED department. So what else do we know about them? In general, prior to this program being undertaken, we didn't know too much. We knew that there was one scoping review that existed on people brought in by police, but that there was limited in-depth multi-site studies. But that provided us with this really unique opportunity to add to the evidence base. There was also a single site study done in Australia, and it was over a 6-month period, and this was very interesting because it actually confirmed some of what we already knew. We knew that people brought in by police were more likely to be male, between the ages of 18 and 49 years old, massive proportions diagnosed with either a mental health and or toxicology diagnosis, a median length of stay of just over 3 hours, and when compared to everybody else, higher percentage of mental health concern and a longer time to be seen. So, undertaking this program, we knew a little bit, but we needed to know more. Okay, so my overarching aim for my PhD was to understand the characteristics, outcomes, and care delivery. So within that, I had a few sub-aims and a few hypotheses that I wanted to test. So I wanted to look at all modes of arrival first and foremost. So people brought in by police versus ambulance versus privately arranged transport. I also wanted to describe these. I wanted to see if I could actually predict some outcomes as well, right? Because what do we usually focus on as clinicians? The outcomes. If an intervention is going to work, we don't know. Let's find out what the outcome is first, right? Before we actually implement it. I also wanted to understand the care delivery from our clinicians who deliver the care. And of course, look at barriers and facilitators related to that care itself. So, to understand it, bear with me, I'm not going to go too much into research methodologies because I know they can be significantly boring. I used a multi-method sequential explanatory design. What this basically means is that I had 3 phases, one informed the next, tested some stuff, found some things out, basically. So instead of trying to make the data talk to each other, my final phase where I looked at clinicians, I interviewed nurses and doctors, those questions stemmed from what I found in retrospective cohort studies. So to underpin all of this, some of you may have heard the Donabedian theory before, the Donabedian framework. It's been around for a very long time, from Avitus Donabedian, great guy. So he posited that there are 3 elements that help to assess quality in healthcare: structures, processes, and outcomes. So those structural attributes represent where the care takes place, the facility resources, the human resources, organisational structure. So it's usually the what in that respect. Then the process attributes are those systems and processes that are taking place. So they can also be defined as whether good care has actually been delivered. And then outcomes, it's what everybody's obsessed with. What's the outcome? What's the relevance? What's the impact on patient and provider? So that was what was underpinning this particular program of research. So I'm going to take you through the 8 publications that stemmed from this particular program. The first of this was a concept synthesis, because when we say the word vulnerability, just to totally put you guys on the spot, what comes to mind? We think of vulnerability, shout it out. What do you think of? Trauma? Absolutely. Sorry? The elderly, yeah. Risk, maybe, susceptibility, lots of different concepts. And it's not just us in healthcare, it's across different domains, different disciplines. So I looked at vulnerability and I'm like, okay, yeah, they're defined as being vulnerable, great, but what does that actually mean? So I undertook a concept synthesis where I wanted to amalgamate all the different research in healthcare pertaining to the concept of vulnerability, and came up with 4 themes. And these were used specifically to target clinicians in the ED. So instead of just saying, this is what vulnerability means, how can you actually identify what a vulnerable patient is or who a vulnerable patient is in the ED itself? So we identified that vulnerability is a journey, that there's elements within an individual's life that perpetuate it, that exacerbate vulnerability. There's positive and negative repercussions. So that was really interesting because we found out from a lot of the resources that we found that there's a lot of life lessons, there's a lot of resilience that can be learnt from these experiences. A shared understanding was the 3rd theme. So the importance of understanding the concept for patient care from both patient and provider themselves. And the 4th theme being susceptibility and risk. So intrinsic and extrinsic elements that contribute to a state of risk. So basically, multiple elements are associated with a vulnerable state, really important when we're talking about the ED and we're talking about that potential, chaotic, fragmented nature of this environment. How do we identify these patients? And that's available in the International Emergency Nursing Journal. So from there, great, had a good understanding of vulnerability, what that actually means, makes sense in relation to people brought in by police, yeah? But there's a journey involved here. It's not just the ED, it's outside of the ED. And this is where things got really interesting because I did a lot of work with interagency throughout this project. And this is sort of where it stemmed from. So I wanted to understand these individuals prior to being brought into the ED. And they're often taken to short-term custodial settings. Okay? There's a lot of literature surrounding prison settings, but not much surrounding short-term custodial settings. Now, short-term can be defined as anything from, an hour to in excess of, they say 6 months, but it depends obviously on the jurisdiction. So in Australia, it's good to understand the terminology as well. We call short-term custodial settings watch houses. In the UK, they're very fancy and they call them custody suites. And in the US, they call them jails. So did a scoping review, found 37 studies. We also looked at the structures, processes and outcomes in relation to this and found 4 themes. So the resources and tools that were prevalent in these articles really prioritise the identification of mental health issues. So they help to facilitate processes in these custodial settings and mainly pertain to addressing mental issues, which is probably not surprising. Additionally, screening and medical assessment was the main healthcare that was delivered. So not even really interventions, just screening and assessment. So especially in relation to drug and alcohol misuse. But interestingly enough, it wasn't really the responsibility of medical officers. It was the responsibility of custodial officers, which presents a little bit of a complication if they're not trained in doing so. We also found that detainee outcomes were varied. So they were reported in about 29 out of the 37 studies, but they were positive and negative. So some of them said, yeah, there were some improvements in symptoms for the detainees, but most were negative in terms of they missed conditions, they missed assessments, there was an exacerbation of their current conditions that necessitated the need to go to the ED itself. And then finally, the actual outcomes for the service itself were limited, which means that the processes and structures that were here are very much highly contextual and they were influenced by the demographic, the location, the individuals involved, and of course, legislative requirements. So what's the point in doing all that? Well, basically, healthcare in these custodial settings is incredibly limited. This is why we're seeing a lot of presentations to the ED, especially when they only focus on mental health problems. Okay, often we know that these patients don't present with one issue, they present with several. So understanding this delivery of care in these settings is a really important initial step to understand care and how to deliver it that's actually targeted towards the detainee themselves. So, knew a bit about that, fantastic. I know I'm jumping here, but I'm jumping to the end of the timeline. Previously, before starting this conversation, I found one scoping review. In my PhD, I decided to do another. Okay, it's been 5 years. What do we know since then? So when I did another scoping review to build on the previous one, I wanted to know what's changed in this time. Has anything changed? What do we currently know and what don't we know? Well, we know that routinely collected data is often used to describe people brought in by police, which makes sense. When we talk about routinely collected data, we talk about data from databases, so the EDC, EDIS, etc. in Australia. But we don't know about broader socio-demographic factors. We don't know about their social determinants of health. We don't know about these other elements that impact their health inequities and disparities. We also know that there is a predominant focus on mental health care, as we said before. But there's limited evidence that actually examines whether it's relevant and whether it's actually effective. We know that there is a relationship between care delivery and outcomes, with disposition from the ED frequently being hospital admission or leaving against the medical advice. But there's minimal detail surrounding care delivery itself. We don't know enough. And finally, a really important point, well, I think it's really important anyway, is that there's actually a lot of growing evidence surrounding police involvement. So police transport of these individuals to the ED itself. There's a growing body of research that does talk about mental health presentations and trauma in this particular population. So that tells us that there's an opportunity here for joined up approaches between police, ambulance, healthcare providers as a whole to facilitate more efficient, more timely care and essentially influence patient outcomes. And that one is published in Australasian Emergency Care. So knowing all the previous bits and pieces that we knew, phase one was about taking a broad scope of everything. So I looked at data that was extracted from the emergency department collection between January 2018 to December 2020, and that was about 4.7 million presentations, which was fun. I learnt some lessons, that's for sure. So I analysed that using Stata, and basically I wanted to find out the differences between these modes of arrival. So earlier I talked about people just brought in by police versus ambulance versus privately arranged transport. So what did I find? So people brought in by ambulance and police had a longer ED length of stay, higher admission rates than people who weren't, people who walked in, caught a bus, caught a taxi, etc. And that suggested to us that there's potentially more complex care needs here. Okay, so that was interesting. Additionally, as another point, which is another postdoc pathway for me, there was an overrepresentation of Aboriginal and or Torres Strait Islander peoples. So 22% versus 9% for people brought in by police versus everybody else. So what from that is there was a number of demographic and clinical differences between the different modes of arrival, which has the capacity to build our EDs in caring for diverse patients and how they arrive, and really targeting interagency strategies that have wider reaching applicability. So we knew the broad scope of things, different modes of arrival, great. I wanted to drill down now into people brought in by police. So using that same data set, I did a subgroup analysis. So of the 4.7 million presentations across Queensland over the 3-year period, just under 1%, about 42,000, were brought in by police. So a very niche population in that respect. So I wanted to see if I could predict an ED length of stay greater than 4 hours and hospital admission. The 4 hours, as you're probably aware of, is that neat target that we tend to have in Australia. So I found that there were a few things that helped to predict length of stay. There are a few things that helped to predict hospital admission, especially when we were talking about things like mental or behavioural issues, or even those complex diagnoses that are sort of subdued under the symptoms, signs and abnormal clinical and laboratory findings, not elsewhere classified. It's a very vague term. But we found out a few things there in that respect. So what did that actually add to what we currently knew? Well, it said that there is the existence of these clinical and demographic aspects between people brought in by police and not brought in by police, but it didn't tell us the strength of the difference. We had about 35% of presentations brought in by police remaining in ED for longer than 4 hours, and 34 who required hospital admission. And that's pretty significant in a very particular population. So there's resourcing implications here, not just for us as clinicians and the EDs themselves, but for police, for ambulance, for the people that bring these individuals in. Okay. So these findings and other findings support the need to understand and develop these specialised care pathways to hopefully expedite care, absolutely. That's an important aspect for us, but to provide better care that reduces the need to stay in the ED for more than 4 hours. So in phase 2, because I wasn't quite done yet, we moved more into the mental health side of things. So I am a mental health clinician, I like to say, and this area is, as we all know, rapidly developing. So within this particular phase, I worked with 17 other co-investigators across Australia, situated with an NHMRC grant. And that basically meant that I worked with a few different individuals to really develop 2 articles from this particular phase. We wanted to know more about mental health presentations, so this stemmed from a data linkage program. Working with Queensland Ambulance, Queensland Police and the Australian Government, we looked at different modes of arrival again. So the data set for this one, we looked specifically at mental health related presentations. So that was a presenting complaint or mental health related ICD code. It could come into the mental and behavioural disorders category, intentional self-harm, or even overdose diagnoses category. So this was between January 2012 to 2017 of December. 31st December 2017. And we looked at just under 500,000 people with a mental health problem. So basically, we were able to find out a few different aspects between the modes of arrival, but it clearly showed that the duration of ED management and care for people with a mental illness relates to mode of arrival. So this could be used to develop care processes further. There's a large recognition of mental health under pressure in our EDs, as I'm sure we all know about. So initiatives to provide mental health care outside of the ED context are growing, as we know, co-responder programs, etc., but they're insufficient. And what does it come down to? Money, resources. So those age-based community interventions, psychiatric decision units, conjointly developed external ED initiatives like tri-response models are promising interventions that do need to be developed further. So from here, again, we wanted to look at factors that were associated with length of stay and hospital admission. So specifically, we were able to look at these independent predictors. The relevance of investigating people as well with a mental health problem stands as an important factor in addressing people brought in by police as a whole, considering that we're looking at 77% come in with a mental health related problem. So we found essentially the association between a longer ED length of stay and more urgent triage categories for people with mental health problems brought in by police indicates that these patients may actually have acute care requirements, so not just a mental health problem in itself. So there's a very strong need that came out from this particular research that indicated the need to implement models of care, especially for older adults who have a mental health problem who are brought in by police. So we can potentially do this. We created some suggestions about looking at care trajectories from police engagement to hospital discharge and beyond, so examining that on a more holistic basis to uncover opportunities for more early intervention rather than reactive responses. And that one's published in Australian Health Review. I'm nearly there, I promise. So phase 3, knowing everything we knew from retro cohort studies, we wanted to now look at the clinicians, because clinicians provide the care, don't they? You're on the ground dealing with all of this. So we wanted to explore the perceptions of Queensland ED clinicians caring for people brought in by police, so nurses and doctors in that respect in the EDs all across Queensland, and understand the experiences that clinicians had. So essentially, we interviewed 9 nurses and 8 doctors, I believe it was, and found out a few different interesting aspects related to structures, processes, and outcomes. So as a whole, what we found here is that the current care delivery for people brought in by police to the ED is very unique and very complex in itself. Often occurs in high traffic, resource intensive areas, which has a massive impact on organisations and throughput. We also found that the interaction between ED staff and police was different according to different participants. Some of them described the interaction as being very positive, others weren't too sure and did have their own stories to tell in that regard. So the relationship between the two individuals may benefit from more collaborative and standardised approaches, which will ultimately have a flow-on effect to people who are brought in by police. What was really interesting, or I thought was interesting anyway, was that the communication processes were very much ad hoc between the two parties, and a lot of participants actually described care as being inadequate based on how they were feeling at the time or the culture of the environment, which was very interesting. And when we're considering a vulnerable population, a very vulnerable population, that's really important information. So, conclusions from the entire program itself is that people brought in by police are unique. They have unique demographic characteristics, clinical characteristics, and outcomes compared to others who arrive to our EDs. There is some evidence surrounding structures, processes, and outcomes, but there's not enough. There's also an opportunity to strengthen what we know, especially in the interagency related side of things, and provide effective care across the entire trajectory, not just at one point in time. Where to from here? Lots of different pathways. I have lots of different plans, but specifically investigating the social determinants of health, focusing on the rurality side of things, so rural remote regions, where we do know that there is a slightly higher proportion of Aboriginal and Torres Strait Islander individuals, and some different, access to health in that respect. There is a need for interagency research. I was very blessed to be able to work with police and ambulance in phase 2 and was further supported in phase 3 with Australasian College of Nursing grant, which was fantastic, but we do need to know more, and we do need to have approaches that are joined up to develop care and deliver it. And there's a need to further understand our ED care delivery to influence models of care. We talk about models of care all the time. This is a great model of care, okay? Why is it a great model of care though? What does it actually do? We are focusing on the majority, not the minority, and it's often the minority are the ones that are undeserved, okay? That's pretty much it for me. I just wanted to acknowledge my supervisors who were very patient throughout my entire project and the multiple organisations involved that gave me the opportunity to be a part of their world. So thank you so much, everyone. If you do have any questions, I'm more than happy to take any.
Awesome. Let's hear it for Rachel. Does anyone have any questions?
Everyone's full from lunch. Yes.
Well, I'm sure Rachel won't mind if you do want to link up with her or anything like that. Shoot us an email. We can get you guys in touch. Otherwise, I'm sure you'll be able to find her here. So
Indeed.
Let's
Thanks
hear
so
her
much.
one more time for Rachel.
Thank you.
So I guess you've all been dying to know what's going to happen next. And so Tanya's very kindly going to be able to move her presentation forward. So what we're going to do is going to roll straight onto the next presentation. There's still a fair bit of food out there, especially edamame beans. There's like a trough of edamame beans. So if anyone likes those, please don't be shy about getting up there and grabbing a handful. Otherwise, we'll roll straight into the next one once it comes up, hopefully now. Let's hear it for Tanya. Tiny. I knew I'd get it wrong. Tiny. Thank you, Tiny.
I know you did. It's because you tried so hard. Hi, everyone. You met me the other day when I was up here with Sam. Thank you so much for having me back on and putting up with me again. Today I'm presenting on beautiful, complex and challenging children with special healthcare needs. It's a bit of a passion project of mine, and I'll share why very soon. That's me. They're the things I do. And probably my favourite thing that I do is I'm a mum of 4 kids and a self-proclaimed CEO of my team, Sticky. Woman Jager, to you, Bunduk, Nick, welcome. How are you? I'm proudly from Naarm in Melbourne. I live, work and play on the unceded lands of the Bunurong and Yorta Yorta people. I pay homage to the connection, strength and wisdom from our ancestors in our learning and teaching today and into the future. I'd also like to acknowledge the land of the God where we gather for this wonderful conference and pay my warmest thanks to the people who call this beautiful island their home, and I recognise their connection to country and traditional customs. So I'll get you just to take a quick look at this picture and keep it in your mind. Simple lac, yeah? Most people will look at that and go, yeah, that's a fairly simple lac. Bring that into the ED or GP clinic potentially, maybe paramedic practitioner. Looks fairly simple. Keep that in mind. So why children with special healthcare needs? One of the most notable trends in child health has been the increased number of children with special healthcare needs. The care of these children is accounting for a growing fraction of healthcare resources across the globe. When compared to other children, children with special healthcare needs have disproportionately high rates of ambulance usage, advanced life support interventions, emergency department presentations, inter-hospital transfers and hospital admissions. This suggests that this cohort of patients and their families and carers have higher incidences of interactions with pre-hospital providers, particularly paramedics. It has been identified by paramedics that attending these patients is inherently stressful. It causes anxiety and discomfort for many reasons, including limited exposure to paediatric cases, assessment of the unwell child, varying training levels, and the emotional elements of dealing with unwell children, particularly those with complex care needs. So who are children with special healthcare needs? They're defined as having an increased risk of chronic physical development or behavioural or emotional conditions who require related health and related services of a type and amount beyond children normally or generally. Now that's a pretty broad statement and a pretty difficult one to throw a blanket right across. So I think that a truer definition of this group of patients is that they're an extraordinary group of children with families and carers who are striving to live with some of the rarest, complex, functional, limiting, technological dependent and life-threatening healthcare problems within the family home and community settings often now. This is a truer reason why. I'm a parent of not one, but two children with special healthcare needs. So I'm going to share a little bit of an honest and bit of a brutal, a bit of an honest and raw account of what it's like to be a parent with a child with special healthcare need, or two of them, as it proves, and also to be a paramedic and so have that medical knowledge, which I'm so very lucky to say. So this isn't really, clinical. It's basically what it's like. So this is us. It is a bit of a raw, honest account of what it's like to be that family. So 17 years ago, I welcomed my second but first bundle of joy, Jonty, to the world. It was his birthday yesterday. And after a very difficult journey to get him earthside, he was perfect in every way. Well, so I thought. About an hour after he was born, he had this episode, and I thought, gee, I looked down at him and I thought, aren't you gorgeous? Except for newborns are really weird. He was doing this horrible blue floppy thing. His eyes were rolling. And all of a sudden, a nurse looked at me and I instantly thought, oh, maybe there is something wrong with him. He was immediately taken from my arms. Alarm sounded. People ran from all angles. I couldn't see him and his tiny little body. All I could see was people and everything was just moving in slow motion. Jonty was transferred out of the small private wing where we were for investigations. Nothing much came of this. He was returned to our loving arms. Several months passed and we'd settled into a routine of family of three until another event occurred. This time I made the statutory, emotional, I think I'm tired, maybe did I see this, I'm not too sure call to my parents, who suggested, like all good parents or bystanders do, you better go to hospital, they'll know what to do. And off I went to the ED. I got there and I never forget what was said to me. The triage nurse who I'd worked in my community alongside with for quite a number of years and delivered many patients, turned around and looked at me and said, I never thought you'd be that parent. What she meant by that was that I was an anxious mum. She was like, I don't think you'll ever be an anxious mum. Why are you here? It is going to be a long time. Go and sit over there. Babies do funny things. I sat down, dejected, exhausted, emotional, sad, not sure what to do. Should I stay? Should I go? I had my medical training, but I just couldn't seem to make a really good decision for my own child. Anyway, sure enough, true to Jonty's form, Jonty performed for me and had another blue floppy episode, and off he was ran into resus. More blood tests, more poking, more prodding, but still no real answers. These events happen time and time again through the first 14 months of his life, all self-limiting. All the times I presented, I got huffed and puffed at sometimes. He had no illnesses, no developmental concerns. They really thought it was no cause for concern. Then at 14 months of age, he had his first tonic-clonic seizure. He fell out of his little toddler bed. He was jerking violently on the floor. He was incontinent and he turned blue. I can still remember what he had on. It's really funny, the things that you remember in a crisis. He had a little blue t-shirt, a smiley face on it. It was one of my favourites. As a paramedic, I knew exactly what it was. It was a seizure. But it wasn't my patient or someone else's loved one or someone else's child. It was my precious boy. I stood motionless, willing him to stop. I wasn't in my blue suit of armour, and this was my baby. It was after this episode that he was diagnosed with epilepsy, and we now know that his first seizure was in fact at an hour old, and that he had seizures of infancy, which is quite common with the type of seizure disorder that he has. He commenced on his anticonvulsants. We had lots of appointments and tests, and we were going to and from lots of places. Our friends and other parents in our parents group were reveling in the new challenges of parenthood, while we were being thrown into the unknown world of unpredictable doctors, waiting rooms, EDs, ambulance trips, and the frightening medical world, which I was so comfy on in my uniform, but definitely not as the mum of a sick kid. Given the frequency and unpredictability of Jonty's seizures, his medications weren't working. He had abnormal scans and we had some inpatient stays. We got told that he could have some brain surgery. Unfortunately, when they went in to do his brain surgery, they basically gave us a really poor prognosis unless we did a full hemispherectomy on him. So the doctors wanted to disconnect his brain. They couldn't give us a guarantee as to what would happen to him. But here we had this little boy who, yes, was having all of these horrible seizure events, but he was running around. He was happy. He could tell us he loved him. So we declined the surgery, and we decided to take quality over quantity. So from there, it was a bit of a rough road. We got told that we'd never see his 10th birthday and to party like he was 18. And I was really first to admit that when I dreamed of a family, I dreamt of that perfect family, genetically blessed, gorgeous looks, doctors, lawyers, pilots, that they'd be exceptional athletes, travel the world and grow up to have the most successful life. We all dare to dream, don't we? It all seemed so insular and insignificant. I felt foolish that I could have thought that these were a happiness measure in life. All of these hopes and dreams I'd had for our family and our future was seemingly pulled from underneath me by this medical condition, and I'd never felt so afraid or alone of what it was like. Here I was hoping I could swap places with our baby boy and holding my breath that the next seizure wouldn't do more damage to his precious little brain. I was hoping he'd be one of those kids everyone's auntie's, uncle's, cousin's, brother's friend grows out of their seizures. I've heard it so many times before. Anyone who's experienced time in hospital with a loved one knows just how tough it is. There's a lack of sleep, the constant worry, being so far from home, you're isolated from families and friends. There's financial burdens, the waiting, the vending machine dinners, and those looks that you get in your room from the passers-by when they know that your kid's really unwell. During one of the hospital admissions, it had been discussed about Jonty's brain surgery and why we had made that decision. And I still stick really clear on my decision and why I did that, and I'm really happy that we made that decision. one of the defining moments for me during one of those hospitalisations was a beautiful team from the Brainwave Foundation, who look after kids with neurological conditions in Australia, came in and gave us a blanket. It was one of the beautiful quilts. And I turned around to her and it had Jonty's name on it. And I said to her, "Oh, aren't they for the sick kids?" And she looked at me, and it was that penny drop moment that I realised that I was the mum of that critically unwell sick kid. I felt really, really alone, and it didn't matter how much our family and friends were there for us. It just felt really alone. We didn't have much contact through the hospital. We were often living in our rooms by ourselves. It was a big reality check that that sick kid is ours. So fast forward on to January 2024, and I make this silly, outlandish statement on my socials. Let's make this year epic, kids. Yep, good. Epic. Epic happened a few days into the new year. Another child, another status seizure event, and we were back thrown into the world of epilepsy and the neurological world again. This time we were home on our beautiful family farm up on the border of New South Wales and Victoria in the northeast. For anyone that's that way, we're just in between Corowa. We're in Waganya. And so we live on my family has a holiday property, and basically it's one of those properties. And if you're in ambulance or pre-hospital world, when you get directions like go to celebrations, we'll meet you there, but then we'll drive you down the driveway because there are no numbers or houses. That's where my family's from. Anyway, we find out the ambulance is about 50 minutes away, so we decide to do this mad dash to the local call the doctor in ED. The poor doctor walked in and I was trying to manage my daughter's airway. I had midazolam because of my eldest son. There was a godsend for something. But I had no way to manage her airway. So I was managing her airway, and I kind of look back at these moments and I like to share them because I have laughed about them. I was in my bikinis. There was a video call to our clinician at work in Ambulance Victoria, to our Piper team, which is similar to Stork, who looks after our paediatric cases, and to New South Wales, to one of the hospitals up in New South Wales because we're over the border. And I looked up and I thought, oh, my colleagues can see me soaking wet from the river in my bikinis. This is a beautiful moment in time. Then my dad said, "Don't worry, I'll get some clothes for you, love." And he bought a Mr. Zimmy jumpsuit that the nurse had to tie me in while I was ventilating my child. The doctor then got told that, we needed to intubate her because of her prolonged status. And he turned to me and said, "Oh, I don't do kids." Oh. So how confident do you think that made me feel as a mum? Then he turned around and went, "How are you at tubing kids?" And it was then that my dad stepped in and said, "Not a chance in hell. That is her child. She will not be tubing her. I don't care what happens. Find me someone to help." So I will continue on with this and in just a second and sort of get to why these little stories are important and how we communicate with people. But yeah, they're my beautiful kids. That's Jonty and Willow. They're two of my four. So just to keep, obviously, just a bit of a thing, these are our list of care teams. These are the people we have probably seen in this 12 months. Okay, so I just want you to keep a little bit of an open mind. Our kids are complex, yeah. Our kids are... We see a lot of different people. So for us to have to go and to get care for from an emergency department, or to seek out care when we've gone past our care plans and we don't know what to do, it takes a lot. Okay, so, and sometimes we're exhausted, we're overloaded, all of the things that sort of seem normal and easy for families that aren't like ours are really not that easy, because we are trying to juggle our entire lives and our children's appointments that look like this. So I guess the families of children with special healthcare needs, we understand each other. We understand how hard it is really to get up and get going, that the simple things in life just really aren't simple. The skips that your heartbeat does when school calls, the entire checklist that you need to ensure nothing's forgotten when you get out the door. Recently I was in New Zealand and I'll explain about that in a second, but I was in New Zealand and I had to take my son's medication over, but he wasn't with me and he'd already arrived in the country because we couldn't get it in Australia, which meant I had to, wait, get the medication, then go. We couldn't get it over there. And so I actually got detained at New Zealand airport for a little bit and had to have an interview about why I was carrying medication without the person being there with me. That was my child who was already in the country. So, simple things aren't just that simple for families like ours. But the best bit about families like ours is that we all understand what it's like when our families get together. It's like a breath of fresh air or the sun hitting your face. You don't judge when children are having seizures. I've been at plenty of epilepsy and brainwave functions and camps where you just basically step over the fitting child at the door and carry on to have your lunch. No one bats an eyelid if someone needs suction or if they need a peg fed. All the siblings understand that birthday parties in the hospital are cool and that, it is okay. We are that family that are looked at sometimes. So considerations for managing children with special healthcare needs. I'm not here to tell you all to suck eggs, but I think history taking is really super important, okay? Communication as well. Obviously, I've given you some examples of the way I was communicated at, and it really has an impact on us moving forward. Family-centred care is so extremely important with our kids. Distraction, de-escalation, care plans. Just reminding parents, have you enacted your care plan? Do you have a care plan? Hospital destination choice, and I'll flick into my next slide in just a second. We'll chat about that. And obviously hospital notification for paramedics coming in. Ask questions. If you don't know, it is okay. I would much rather be asked, what does that mean for your child? How do we do that? What does this mean? Can they have this infusion? Than have someone pretend that they think they know, run out, Google and not understand it and then set up the wrong infusion, okay? And I always say, have you ever? We've all Googled, we've all Dr. Googled, oh, what does this mean? It makes us feel uncomfortable, okay? I have too. But there is no shame in asking your patients, particularly those with complex care needs, how or why, and saying you don't understand. Parents would much rather that. So where has this led me to? And I understand this isn't a research conference, but this has led me to a bit of a love child of mine. So I have started an honours project about patient care and paramedic choice for destination for children with special healthcare needs. So I've conducted a scoping review. I'm not going to step you all the way through it, but basically that's my inclusion criteria and things. It's basically kids with special healthcare needs. They're my methods. We'll just get through my data analysis and everything like this, and I'll just get right through to the end. We had lots of study limitations, a lot of the evidence. There is no data here in Australia. It's all USA based. It's very difficult to define what is a child with a special healthcare need. And there was lots of demographic issues. We used only articles that were in full English, so we may have missed some. So I guess this is the most important part for me, is that my next phase is to conduct a reflective thematic analysis and qual research to explore interactions between parent and carers of children with special healthcare needs and how decisions are made with regards to hospital destination choice. And why it's so important to make good early decisions on where we take these children. So my future aim for paramedic practice with my studies and where I'm going with this is to write a clinical practice guideline for transport decision making with children with special healthcare needs. It's to increase awareness in the training and pre-hospital paramedic space to ensure that parents and carers of special healthcare needs are heard, supported and included in decision making, as family-centred care has been proven to improve patient outcomes. I want to be a driver for change in paramedic practice while advocating for families who have been thrown into this parenting journey which they never ever imagined. They're my references. So I go back to this headlack. Simple head lack still. Okay, this belongs to my child. This wasn't a seizure event. This was teenage boys being teenage boys at school. One of his mates, boop, up his bottom into the locker, splits his head open. He rings me from school and says, I think I'll just catch the bus home. It's my brother's birthday and I've ruined enough of those. Anyway, the school nurse won't let him get on the school bus. My mum collects him for me and she goes, I'll run him up the local doctor. Local doctor goes, oh, I can't do that. Better go to the local ED. The local ED goes, oh, that needs plastics. Plastics go, oh, we don't like his history. Oh, yeah, nah, can't be here. So 9 hours later, plastics fix that in his primary care hospital facility where all of his history is, because they were happy to do so, whereas other settings were not so happy with his complex care history, his history of his anaesthetics and things like that. So sometimes we can see these kids walk in and go, yep, simple, but not that simple until we delve into that really good clinical approach. I understand that not every neurologist, not every specialist is going to be in an ED 24/7. I'm not expecting that kids with special healthcare needs get taken, to EDs just for the sake of it. But what I'm saying is I'd really love to see some forethought to decrease the inter-hospital transfers, to decrease the amount of hours for families like mine in the emergency department, to decrease those chances of needing to be moved on to the next hospital and all of the care that's required in between there. So I would just like to say thank you, obviously, family, friends, colleagues who have supported us and me and continue to support me. To the parents and carers of beautiful kids like mine, I see you, I hear you, and I do promise I will try and make a difference for you. Our amazing care teams, we couldn't have 2 children like we do and 2 other children like we do as well without them. Thank you to Department of Paramedicine at Monash University who have supported me through this. But a big thank you goes to my eldest son, Jonty. So he said to me, no matter what what challenges life throws at you, you can make a difference, Mum. And he prompted me to do this. He said he wanted me to leave a legacy should anything ever happen to him. He was sitting in ED once, about ready to be shipped out again, and he was really upset that we had to go on an inter-hospital transfer. And he just said to me, Mum, there has to be a better way for kids and families like ours to get the care that they need in the hospital that looks after them and understands them the best. Can you do this for me? So that is Jonty, and he is now, as I said, 17, and he is excelling. He still has his seizure disorder, but he is playing netball for Victoria and Australia. So he's currently away at Netball Nationals. So very proud mum. But yeah, that's it. And thank you so much, Quint and Dill, for having me. Like, what an honour to be able to present here.
All right. Well, I just want to say one last big thank you for sharing such a great personal story, and it's really inspiring what you're doing. So hopefully you all got something out of that one, and let's hear it one more time.
Thank you. Thanks.
All right, let's take 5, grab some edamame beans, then let's give away some prizes. using Paddy because got the microphone's on now. They said to keep it used to you. Heads up. It's just on my iPad. I'll hold it up. I think I'll tweet them up there, so maybe that gives some feedback that you can give me potentially read it. Like I've been doing it, but I've actually just thought I could do it on my iPad. Yeah. Excellent. Yeah. Perfect. Great. We got great. Excellent. How did you pick this up? I think it's a thing. All right. What's that? Yeah. Alrighty, it's our last photo session time. But before we go to our photos and remembering the loudest cheer gets the prize, we did have some sunglasses that were left in the room either yesterday or the day before. So if these look familiar or you know who those may be, we'll just have them at the front of the room if you want to come grab those ones. All right. We've got 3 prizes. We're not going home with any of these prizes, so make sure that we do some cheers. I think we have about 10 or so photos. So let's get straight into it with our first one. It's not bad. Photo for Insta. I like it. Oh, and it was for their 30th wedding anniversary. So for another round of applause. Yeah, I think you have to get a prize for that, actually. So there we go. There's 2 prizes left. There we go. Another sunset, Jimbar and Bay. Nice. Oh, look at that. It's like some good fun from the ATV tour. Get ready for the next one. I won't make any more comments on that one. Yeah, pretty, yeah. That's more of a, than a cheer. I like it, though. Oh, bike riding to the rice paddies. I hope that was an e-bike because I imagine that would have been quite hot. Oh, someone getting creative. Oh, hashtag EMS. Yeah, I like that one. Well done. Good work, guys. Oh, meerkats. Oh, 3 meerkats on the lap. I hope it's at the zoo and not anywhere else. Sorry, dude. Horse riding on the beach. Yeah. So this is on like Postcards WA or something like that. Oh, there we go. And a monkey who stole a phone. Yeah, nice one. All right, I think we've got some clear winners today. So we've got the 30-year wedding anniversary. We've got the going through the water and they're all getting sprayed up, and I reckon this one. So big round of applause for everyone who submitted their photos. It is something that we enjoy seeing them all come in. So thank you very much for those ones. Please feel free to keep tagging us as you continue your travels throughout Bali. And it's always a fun one to keep an eye on when we do have our conferences running. Certainly the Japan one often gets some pretty wild photos going on there. 2 more presentations left. I think we should give an extra round of applause for our next presenter who, when we were trying to transfer the presentation across, we lost about half of it. That she's absolutely done a stellar job, put it all back in together. And so let's hear it for Erin as she comes up to stage.
Hi everyone, my name's Erin. Can everyone hear me all good? Yeah? My name's Erin. As Quentin said, apologies because I've lost probably the middle of my presentation. So it's a bit light, but anyway, we'll get through it quickly and that's a positive. Are you all good? Thanks, it's a day for it. So yeah, as I said, my name's Erin. I'm a nurse practitioner. My specialty is emergency, but I also do GP a day a week. And I do rural, remote and palliative and aged care as well. My primary job at the moment, I work locum, obviously around rural, remote as well, but I also do a lot of night shift for Victorian Virtual Emergency. Have I met anyone on that at all? Put your hand up if I have. Maybe not. Yeah? Hey, how are you? So often do night shifts, and as you would know, there's not much really to resource-wise to go with. So often we have to work very closely with paramedics to get people hopefully out of hospital is the main goal. So some of the cases I got here relate to that. Some are just quick ones just from my face-to-face work as well. So first case I saw face-to-face, so a rural emergency department. So it's a quick one. 36-year-old female. She presents with a gradual onset of shortness of breath, a productive cough. The reason for presenting to emergency was that she had some very mild chest pain that she described was worse on coughing, but sort of worse when she lied down, but she wasn't sure if that was due to coughing or not. She presents to triage with body aches, she's got a mild sore throat, fatigue, and a low-grade fever. That's her obs. You see them all there? Yeah, so obs are looking not too bad really, if you look at it from triage point of view. So past medical history, she's had a COVID infection 6 weeks ago, and poor thing got influenza 3 weeks ago. She's been recovering okay, but obviously had this persistent cough going on for that time. As far as her social family history stuff, she runs daily. She's pretty fit and healthy and looks fit, healthy and well. She's got no cardiac risk factors, obviously no travel. She reports she feels constantly run down. She's caring for small children, always feels tired, feels like she always gets sick. So has anyone got any thoughts on what this could be? What's the worst thing it could be? Yeah, nice. What's the most benign thing it could be? What would you think of triage emergency nurses? What would you think this would be? Or you see this a lot? Yeah? Yeah? What about something that's just, we see every day coming in with a cough? Yeah, post-viral cough? Musculoskeletal pain? Yeah? So these are our list, obviously. We've covered some. So obviously ACS is our, big ticket item, especially triage. PE, myocarditis, pericarditis, pneumothorax, would be unfortunate, pleural effusions, pneumonia, early sepsis, and then what we often see a lot at triage is upper respiratory tract infection and normal post-viral coughing and pain. So, sorry, this is small because I've lost this page, but it does say, so obs there are the same. So the only real thing there, obviously you've got elevated heart rate of 108, but hey, when someone's got post-flu, post-viral stuff, a bit dehydrated, nothing really that remarkable. Her ECG was sinus tachy. VBG was normal lactate, normal basic bloods, normal chest x-ray, but her troponin was elevated. So it was over the equivocal range where we worked. We didn't have high sensitivity. I can't remember what it was, sorry. But it was at the point where it was elevated, but we couldn't work out why. So what we did next, we discussed with cardiology at our receiving hospital, Metro. Their working diagnosis, the gentleman in the back, well done, was myocarditis. She wasn't allowed to go home, so we had to just put her in cardiac monitoring for 48 hours in our ED, because that's where patients go when they're monitored. And awaiting non-urgent, because she's stable, RFDS transport to Perth. In Perth, and I didn't have all the details, so it's a bit brief. I only saw her in the street probably a month later. So this is her story. So she got diagnosed with myocarditis in Perth, and she started a beta blocker. She was under cardiology outpatient sort of reviews once a week or so. And she made a full recovery within about 2 to 3 months. So it was more supportive care. So just some symptoms to think about with myocarditis. So you can have no symptoms. Obviously that's mild. A lot of us may have that with a COVID or a post-viral infection. So chest pain may or may not be present. Fatigue, shortness of breath, palpitations that come and go, or may have had a period of palpitations that have now resolved. May or may not have a fever, may or may not be tired. Body aches, can have them. So ECG findings can be many things. So I don't have any copies, sorry, because I've lost some slides. But sinus tachycardia is one. You can have an ECG with some just non-specific ST elevation. And you can also have some ECGs with some just strange T-wave like inversion or just nothing specific that really points to anything in particular. In the worst case, so obviously what we're trying to prevent or support with these patients is cardiogenic shock and death. So sometimes that can happen suddenly, sometimes it can happen over a period of time. So there's no curative treatment for myocarditis. The focus is on supportive care. It's usually self-resolving, and it can be caused by different things. So post-viral is the one I've got, but there's other conditions like lupus or things like that. There's a whole list of other things that can cause myocarditis, but I've just focused on this one. Recovery time is usually within several months. Some people will be on beta blockers, some will be on diuretics, some will be on other type ACE inhibitors, those type of things. And we're just looking for a deterioration, so cardiac failure or things like that. And obviously then they would go to ICU for supportive care. The lesson I learnt from this case, this is probably about a year old, this case, was we shouldn't assume that chest pain with viral symptoms or cough, colds, runny nose and sounding very pleuritic can be myocarditis. And I suppose without a troponin, we don't know. So that was my take-home message, to maybe not dismiss those presentations, especially virtually as well. I send all of them to hospital. Has anyone got any questions or anything exciting that they've seen about myocarditis? No? All good? All right. So this is our next case. So as I said, I'm doing a lot of, who's from Victoria here? Who's heard about whooping cough all happening everywhere? Right, so this is for you guys. So I'm getting asked a lot by a lot of parents when I see kids, mainly virtually in Victoria. My child has been coughing until they vomit. How do I get them tested for whooping cough? Now, this has been a very frequent presentation before whooping cough was even, sort of flagged as a thing. And the previous treatment for that was basically time and monitoring and looking out for deterioration. It wasn't the magic antibiotic bullet, I suppose. Sorry, my computer's frozen. So whooping cough, its initial symptoms start with a cough, runny nose, tiredness, low-grade fever, pretty much similar to stock standard upper respiratory tract infections. Usually after 1 to 2 weeks of illness, like the viral-ish symptoms sort of resolve, but you're left with the rapid coughing fits, particularly at night, and post-cough vomits. They're described as having a long inspiratory effort, and that whoop sound that you would have heard, I'm sure, on the internet or YouTube. The cough can come and go over a period of months, which is very common to what we'd see with any post-viral cough as well. So there's nothing that really changes there, but I suppose we're just on alert that maybe some people need to be tested, some don't. In infants, especially under 6 months, they're more subtle signs, as you'd know, with infants of that age. So some signs may not be the intermittent coughing, but especially in the, neonatal. So apneas, mild cyanosis, feeding difficulties or starting to miss feeds, or that what parents describe as choking episodes, which also are very common presentations for that age group as well, that we see without whooping cough. In adults and adolescents, we see like an illness and then it resolves a little bit and then they're left with these sort of coughing fits that predominantly are at night time. But it's quite hard to distinguish that group. So testing, so I suppose this mum's question to me is who gets tested and how you test. So it's a PCR test. It's most sensitive within the first 3 weeks of illness, but it can also be positive up to 5 weeks after the first initial symptoms. In infants with a history of cough, choking, sorry, it's spelled wrong, gasping and breathlessness, even without close contact, they should be tested. So when we're thinking infants, that high-risk group is the under 6-month group. The mode of transmission, sorry guys, is droplet transmission, highly contagious, and the period that you can catch it is 21 days after the start of a cough, 14 days after the start of what people describe as night coughing, and after 5 days of completion of an appropriate antibiotic course. So if you are tested for pertussis, a positive PCR obviously is a notifiable infection that needs to be reported. You've got 5 days to make that report. So antibiotics is obviously the choice that can be given. The goal of antibiotics is not so much to treat the illness, it's more to reduce that period of transmission. So as you saw on the previous slide, you've got that 5 days after starting antibiotics that you can no longer pass it on to somebody else. So I suppose the goal for us, whether we work out of ED, GP or in EDs, is to consider who are the higher risk people who we need to do the PCR on, or who is in contact with those high risk people as well. So close contacts of a confirmed case are considered close family members, close family and household members, people who stayed overnight, sorry, another typo, in the same room as a case, and people who have had face-to-face contact for an hour or longer period. So that would be us healthcare workers. If you are obviously caring for a case that you didn't know of, that would be where you would become a contact if you came in contact for that period of time. So the high-risk contacts are the ones who receive, so the following high-risk groups will receive prophylactic antibiotics. So we get a lot of people calling in saying that they need antibiotics because they've known a case of a case of a case. This defines who those people are. So expectant parents, so both obviously a pregnant person but also their partner, but also the carers who are going to be around the newborn baby. So people who are in their last months of pregnancy or around somebody who is expecting in that last month. All household members where there is an infant under the age of 6 months. So it's about protecting that 6-month-old by giving prophylactic antibiotics to that group of people to reduce that mode that they can catch it, the time frame. Healthcare workers who care for women in the last month of pregnancy or infants aged under 6 months. So that could be emergency nurses, paramedics, also obviously neonatal workers and paediatric nurses as well. Childcare workers who care for children under 6 months and children who attend daycare who have brothers or sisters basically of under 6 months old. So those are the people that we give prophylactic antibiotics to if they have been around a confirmed case. So once you get that confirmed case, these are the questions you need to ask and consider. Has anyone, sorry, that was a bit wordy because my slide didn't have any pictures on it because it was deleted, but has anyone got any questions about any of that? Has anyone done any contact tracing or anything like that for anyone with whooping cough? No? All right, last case, guys. This is a palliative patient that I saw in the middle of the night. Hope it wasn't your patient. Who I've seen virtually. So I was contacted, it would have been about 2 a.m, to see whether this patient could either be palliated at home or if this patient needed to be transported to hospital. It was a tricky case emotionally for the crew, for me personally, and obviously the patient and family as well. So as a 75-year-old end stages COPD patient who had a sudden exacerbation of COPD at home. She was linked in with the palliative care team and had morphine midazolam delivered to their house that night. The plan for her then was to have palliative care team visit in the morning to educate them on how to use that medication and also just the general dying process and those sort of things. So the patient's goal and goals of care was that she wanted to die at home with family support. In the home, she had her son there, but also it was a really big extended family that lived in the house as well, and multiple people living overseas who needed to be called very frequently during the consult as well. She was looking really unwell. She was barely conscious. She had a BP of 80/60, respiratory rate of 32, SATs were unrecordable, heart rate 145, temperature was 35.9. The paramedic crew, rightly so, was really concerned that this patient would die en route to ED or whilst obviously being ramped or in ED without family. And that was their main concern, obviously, that they wanted to respect the goals of care of the patient as well, who now actually couldn't really give us much consent because she was barely conscious. So the paramedics' thoughts and wishes were that we could hopefully educate them on how to use the morphine midazolam and get them through the morning until the palliative care team arrived, which we didn't know what time it was. It was sort of a roughie about when they'd arrive. So when I took the son away from the family, because it was a bit of a chaotic situation just with family, I took the son away privately to have a talk to him about how he felt about palliating his mum at home with these boxes of medication that he'd just received. He hadn't quite emotionally accepted that his mum was palliative, so he was in that mind that he expressed to me that once a month she gets his mother gets like this, but bounces back quickly with an ED visit with some O2, IV antibiotics and some steroids. Now, ED nurses, how many COPD patients have you seen in your career that just keep coming back, and every time they come, you think it's their last time. But then a few weeks later, I don't know, for me, I live in a small town, I see them down the street. So they're resilient in many ways with their respiratory reserves. So I spoke to the son and he said officially she is NFR, but she's for basic ED treatments like IV antibiotics, steroids, things like that. The son expressed that even though he wants to respect his mum's wishes, that he's terrified of needles personally, and he hasn't received any education on how to deliver the subcut medications. He has no idea about the dying process. He expressed that he has no idea about what signs of pain were, how to assess if his mum's suffering, and he had a really thing in the back of his mind that he didn't want to be responsible for giving his mum a bad death, was his thoughts. So as I said, it's the middle of the night. There's no one open except for the paramedics and me and ED. Palliative care are coming in the morning. So I suppose we were left with three choices from what I could see. So one, we could transport the ED patient, so transport the patient to ED and risk them dying either in ED, en route or ramped. And that is against, obviously, the patient's goals of care originally. We could give some bolus palliative care meds and hope for the best, which I have done many nights before. Or we could give some bolus meds and teach the family how to administer further. So the way that I approached this is I was upfront with the family and I said of each of the options. So one, if you transport to ED and we get some treatments, obviously his mum is going to be having another exacerbation within 1 to 2 weeks. That was her frequent pattern. I expressed that there is a real risk that she could die en route alone and without them, or in a busy ED environment where nurses may not be able to get to them in time or check out medications in time. It may not be a good death, is how I worded it. 2, I talked about what the pros and cons of 2 are. So we can give some bolus palliative care medications. They don't last long, and we don't know when the palliative care is coming, and they may run out, and his mum may be left to die without any medications. 3, the risk of that was obviously give some bolus medications, and I was happy to consider liaising with them during the night to teach them how to administer subcut over the night if they needed more doses. Having said that, he was even terrified to open a vial, which I felt like when I first started nursing. I don't know about you guys. So after having a frank conversation, the son expressed that he wanted transfer for basic interventions. He was too afraid to give the medications. He didn't want that burden, psychological burden, on himself, which is fair. He was transported to ED. She was transported to ED with the crew. And it was difficult. Obviously, the crew felt really responsible for that. I felt really responsible for that, and the family also didn't feel that they were following their mum's wishes, so it was a bit tricky. So I followed up the patient briefly a few weeks later, and I saw in the notes that she did get treated with O2, steroids and IV antibiotics, and she went home pretty well after a few days in hospital on oxygen. I suppose the positive from this case is that it gave the son some time to prepare both psychologically but also receive some education on if he can administer these medications at home, and also about the dying process and how to prepare for that and what to expect, and only obviously negative outcomes that can come, negative symptoms and distressing symptoms that can come with somebody in the dying process. That's it, guys. Has anyone got any questions? No? All good? All right, thank you.
Thank you very much, Erin. And we're going to move straight on to our final presentation, not just for today, but for the whole week. So as I bring the presentation up, I might call up Kim and Talia. And Kim and Talia, for those who have been to one of our conferences before, are becoming very familiar faces. We feel very privileged that Kim's a great supporter of EMS Conferences and Bali. And I think this is about the 4th time she's presented. We know it's going to be great, and we hope that you guys enjoy it as much as we do. So big round of applause for Kim and Talia.
Thanks, Quentin. Gee, I wish I got that rap every day at work. That would make me want to work more, wouldn't it? So while we're just pulling up the presentation, I might just introduce myself. So my name is Kim. I'm a CNC. I've been working in mental health for, it makes me old, 34 years. Talia is also a CNC and is actually my daughter. So it's a mother-daughter presentation. So Talia is also a CNC and works in the mental health team in ED. So my current role is I am one of the co-responders in Queensland. So I work with the ambulance and I work with the police. So I think it was Rachel, I'm not sure if she's still here, which she did a really great presentation on around police bringing people to ED. So that is often my role, as well as working with the ambulance. And Taylor is currently one of our, what we call our MECO, which is a new position at Gold Coast ED, as well as Rabina. And Taylor can give you a bit of a brief on what she does at the moment.
Evening. So essentially it's the mental health emergency coordinator. So we work alongside the medical commander or senior registrar or the ED-CNC, providing front-end dual triage to determine most appropriate pathways. So looking at trying to improve the patient's journey who's presenting in mental health crises, so they're not waiting in a waiting room for 7 hours unnecessarily. Or advocating for further medical workup or medications or anything like that, just to improve their journey in the...
Yep, great. Thanks, Talia. Before the MECO position, we have presented previously on our rapid response model, which was the lead up to the MECO position. And what we did realise when we did a 6-month study is in actually having that mental health clinician at front triage, we actually could reduce our code blacks, which is our aggression, by 22%, which was, a great outcome. So I think having the MECO position ongoing is a really good role to have an AD. So before we move on, I think I'd like to just thank Quentin Dillon with his Bali Belly. Sorry, Dylan, for outing you on that. The conference facilitators and all the sponsors, as well as my colleagues here, who I can see Sarah at the front, who is one of our nurse practitioners and supports us very well as mental health clinicians. As mental health clinicians, I really like to be interactive. I know lots of people don't like that, so I'm not going to do a lot of that today, but there will be some space for some reflection, and I will be asking questions and some feedback from the group. So ideally, I always like to know my audience. So hands up anybody who works in ED as a nurse. Great. Okay. Hands up anybody that works in ED as a doctor. Yep. Great. Okay. Allied health in ED? Okay. Any paramedics? Great. Any paramedics from Queensland? Yay. So have you guys heard about the co-responder program where you work? Do you have a co-responder program? Wonderful. Yep. Anybody from Gold Coast area? Okay. Anybody that works in mental health in the room? Wonderful, one. The reason why I'm such a so passionate about presenting at these conferences is I think that mental health is a big part of emergency presentations. Yeah? Can we all acknowledge that mental health is growing? We can put in place all these programs. Mental health is still going to present to ED. So I think we really need to have a good understanding about mental health and how we can better manage. Trauma-informed care is a passion of Talia and myself, and I think when we get through, hopefully, we can look at whether or not what we've presented has made a difference. Is anybody aware of trauma-informed care? Does anybody find it hard dealing with mental health patients in ED? Yeah, lots of nods. There's a hand up there. Great. Okay. Has anybody done any training in trauma-informed care? Sorry, I missed. Absolutely. And hence why I think we developed our co-responder program. So on the Gold Coast at the moment, we're keeping out 66% from coming into ED. So as we start, we'd just like to acknowledge the universality of the trauma experience and welcome anyone in the room who has a lived experience of trauma. It's our intention to ensure that you feel safe and cared for while you're learning. And if any information becomes overwhelming at any point, feel free to take a break, walk out. If you feel you need to catch up with us later on, please do so. Our intention is not to re-traumatise trauma.
So the aims of this presentation, we're looking at defining trauma, looking at adverse childhood experiences and how these affect brain development, trauma-informed care, what those principles are, and the benefits of trauma-informed care. So just quickly as a reflection, can we briefly reflect on a consumer who we may have cared for or who may present frequently that you think has a history of trauma? And what is difficult in our management of these consumers?
So if you just take a couple of minutes just to reflect on that, and I might just write a few things on the whiteboard just to keep it there for the whole talk so we can reflect on what's up on the whiteboard while we speak. So probably 1 minute, and I'm trying to run to time, so Quentin keeps me to time very well. And in doing this talk, look, I normally would do a 2-day workshop on this talk. What we've tried to do is condense information into 60 minutes for you guys, okay? Just to give some basic understanding about what trauma-informed care is. So just briefly have a think. When you're ready, just shout out some ideas on what is the difficulty in managing these patients, and I'll write it up. Right. Anybody want to yell something out? So you mean like demanding behaviour?
Or time constraints?
Okay. What was that one, Tally? So we've got time constraints.
You got manipulative?
Oh, okay. Not the red. How about I try the black? Can you all hear me if I don't use the microphone if I yell? Tally's used to me yelling anyway, by the way, so maybe I've induced trauma in my child. Oh.
What kind of behaviours?
So behaviour in the waiting room? Yeah. Substance abuse, was that? Absolutely, yep. So our frequent presenters with burnout, for us, yep. What was that?
So a mixture of the two? There's some
Absolutely.
complexity to it.
Yeah, and that's my big bugbear. So it's another talk, but I always talk about the overshadowing with mental health patients. So often with mental health, there's a lot of overshadowing and lots of the physical health gets missed. Same with our substance abusers. Yep. Anybody else? Absolutely. Yep.
So environmental challenges, like the environmental space and... Yep.
Yep.
Anybody else before we move on?
Yep, absolutely. That's my big bugbear with my own team, but yep, absolutely.
I think there is one more.
So we've actually changed at Gold Coast. So we have fit for assessment. There does not need to be a medical clearance, and nor should there ever be medical clearance for a mental health patient. Unless there's a need that something that we're worried about is causing the mental health presentation. Yeah, all we're doing is prolonging this person's wait. Yep.
Is there anything else before we move on to the next?
Yep.
So
Okay.
limited resources in that sense?
Limitation.
It would be nice.
What was that one?
Space? Appropriate space? No, it's not. Yeah. Yeah.
So a bit of confliction in the acts and treatment.
Okay.
Yep. Yeah, absolutely. As we all would if we, if we're distressed and we need something, and we've got nowhere to go. And yep, absolutely. So,
All right. Kim?
that's great, guys. Yep. So that wait time.
Yeah.
Absolutely. Yep.
All right. Just being mindful of time, we might move on, but we'll keep those there on the whiteboard. If we can flick back to the slides. So the Substance Abuse and Mental Health Services Administration defines trauma as an individual's trauma results from an event, series of events, or set of circumstances that is experienced by that individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on their functioning and mental, physical, social, emotional, and spiritual well-being. So when we look at trauma, a large percentage of the population have experienced trauma, making it essential to consider in emergency department presentations. There can be different types of trauma. This can include physical, so injuries, motor vehicle accidents, abuse, emotional, childhood neglect, domestic family violence, and psychological, from PTSD to complex trauma. So common reactions to trauma include hypervigilance, emotional dysregulation, difficulty accessing healthcare, and difficulty trusting others.
So then if we look at complex trauma, so we have trauma and we have complex trauma. So trauma can arise from a single or repeated adverse event that threatens to overwhelm a person's ability to cope. When it's repeated and extreme and occurs over a long time or is perpetuated in childhood by caregivers, it's called complex trauma. So often you'll hear people talk about trauma and complex trauma or complex PTSD. So what we're talking about now is that complex PTSD. So 2/3 of people presenting to mental health services, inpatient and outpatient, have a lived experience of child physical or sexual abuse. That's massive. 2/3 we're talking about. Other causes of complex trauma include emotional abuse, neglect, family violence, living with a parent with mental illness or that abuses substances. We've got our war and refugees trauma and separation and loss. So in Australia, 5 million adults have been affected by childhood trauma. Again, that's a huge percentage that we're talking about. It's not little numbers. Trauma can affect individuals, families, groups, communities, generations, and it overwhelms people. And it can also ignite that fight, flight, or freeze response. You would have all heard of fight or flight or freeze. Yep. And trauma can produce that sense of fear, vulnerability, and helplessness.
So who here has heard of adverse childhood experiences or ACEs? Do we feel like we have a good understanding of what ACEs is? Yay, nay?
Do you think you need more understanding about what ACEs are? And that's what this talk came about. Last year in Bali, I think we presented on something, and it raised around trauma-informed care. And there's a lot of people that were saying we need more education around ACEs and around trauma-informed care. So we're going to play this video, and I think when you watch it, I think it will startle you about the impact that trauma actually has, not only on mental health, but on physical health.
What we found in the ACE study, involving 17,500 middle-class adults, was that life experiences in childhood that are lost in time and then further protected by shame and by secrecy and by social taboos against inquiry into certain realms of human experience, that those life experiences play out powerfully and proportionately a half-century later in terms of emotional state, in terms of biomedical disease, in terms of life expectancy. In 1985, I first became interested in developmental life experiences in early childhood, really by accident. In the major obesity program we were running, a young woman came into the program. She was 28 years old and weighed 408 pounds, asked us if we could help her with her problem, and in 51 weeks took her from 408 to 132. And thought, well, my God, we've got this problem licked. This is going to be a world-famous department here. She maintained her weight at 132 for several weeks, and then in one 3-week period regained 37 pounds in 3 weeks, which I had not previously conceived as being physiologically possible. That was triggered by being sexually propositioned at work by a much older man, as she described him. And in short order, she was back over 400 pounds faster than she had lost the weight. I remember asking her why the extreme response, after initially claiming not to have any understanding of why the extreme response. Ultimately, she told me of a lengthy incest history with her grandfather from age 10 to age 21. Ultimately, it turned out that 55% of the people in our obesity program acknowledged a history of childhood sexual abuse. I mean, that obviously is not the only issue going on, but it was where we began. And as we went down that trail, then we discovered other forms of abuse, also growing up in massively dysfunctional households, etc. And the ACE study was really designed to see whether these things existed at all in a general population, and if so, how did they play out over time. We studied 10 categories of adverse life experience that were chosen because of their prevalence in the WAIT program: childhood sexual abuse, heavy-duty childhood physical abuse, I'm not talking spanking, major emotional abuse, recurrent humiliation, 2 categories of neglect, growing up in a home where one of the members of the household was chronically depressed, suicidal, mentally ill, or in the state hospital, growing up in a home without both biological parents, growing up in a home where one of the members of your household was alcoholic or a drug user, growing up in a home where mother was beaten, growing up in a home where one of the members of your household was imprisoned during your childhood or adolescence. Those were the 10 categories. In a middle-class population, 1 in 11 people has experienced 6 or more of those adverse life experiences in childhood. So this is very common, totally unrecognized. It was difficult for us to accept their commonness, but on the other hand, these are issues that most people never touch. And so who would know without routinely asking? But at a so-called ACE score 6, experiencing any 6 of the 10 categories that we studied, that person was 4,600% more likely to become an IV drug user than a person who had experienced none of those 10 categories. Okay? Now, you think, you read in the newspaper the latest cancer scare of the week, prostate cancer or breast cancer increases 30% and everyone goes nuts. I'm talking 4,600% increase. The same ACE score of 6 produces a likelihood of attempting suicide that is between 3,100 and 5,000% greater than the likelihood of suicide attempts in someone with none of those life experiences. So the power of this relationship is enormous. So ultimately the question arises, how do life experiences in childhood end up with disease states a half century later? There are at least 2 big categories to account for that. One is through the use of various coping devices. One smokes to feel better, one overeats to feel better, one drinks to relax, etc. And those things carried out in heavy amounts have major destructive patterns, even though they may be immediately beneficial. The other broad category has to do with the effect of chronic major unrelieved stress on the workings of one's brain and central nervous system. In recent years, this is relatively new, it's become clear that chronic major unrelieved stress can produce the release of pro-inflammatory chemicals in a person's body and also can suppress immune system function. Of the 10 categories that we studied, any 6 of them produces a shortening in life expectancy of almost 20 years. The magnitude of this problem is so huge, and the complexity of dealing with it after the fact is so huge, that realistically the only serious approach is going to have to involve primary prevention. No one knows how to do that, but it's the right question to focus on.
So those figures astound you? Like, they're massive. They're in the 4,000 to 5,000%. Okay, so this is not just affecting mental health, it's affecting physical health. 20 years, that's massive. So why, as a health community, do we accept that? And it's something I want you to just think about as we go along for the talk. It's massive. 20 years cut off your life, all because you have experienced an adverse childhood experience. And most people do. And it was interesting, it's middle class. So you could say that's underreported. So lots of middle class people do not report what's actually happened or happening.
So it's been explained in the video, but just to go over it, adverse childhood experiences is a term used to describe stressful events or circumstances that children may experience during their childhood. The CDC Kaiser Permanente Adverse Childhood Experiences Study is one of the largest investigations of childhood abuse and neglect, household challenges, and later health and well-being issues. Yeah, my mistake, left out a word. So as said in the video, there are said categories. So abuse, you've got your physical, emotional, and sexual. Under neglect, you've got your physical and you've got your emotional, and in household dysfunction, you've got a parent with a mental illness, an incarcerated relative, domestic family violence, substance abuse, and divorce. Now, in saying that, not everybody who is exposed to an adverse childhood event will experience the difficulties that we're talking about today. So the ACEs study proposes that stressful or traumatic childhood experiences have a negative neurodevelopmental impact that leads through the pathways and increase the risk of a variety of behavioural, health and social problems. So the ACEs pyramid is used to depict this concept. So from contraception, you've got your adverse childhood experiences, then you've got your disrupted neurodevelopmental, social, emotional and cognitive impairment, adaptation of health risk behaviours, and then you've got your disease, disability and social problems, and then early death.
So if we just have another brief discussion, because I love to be a little bit interactive, so I'm sorry about that. So what do you think about the prevalence of ACEs in Australia? What do you think it could be and why? Why do you think this is so? So you want to shout some things out to me and What do you think the prevalences of adverse childhood events in Australia could be? Do you think it's high? Yep. Yep. Why? Why do you think it's high? Yep. Yep. Yep, absolutely. And we know this. Studies are showing us this. Yet we tend to not turn a blind eye, but I would put the question, why aren't we studying this further? If it's causing such a health issue, why are we not looking into why this is? Yeah. There's also a lot of stigmatization. People don't want to say what's really happening, or people aren't given the right opportunity to say what's happening. Yeah. People are worried about the stigma and the bias. And let's face it, we all have bias. That's a human response. Everybody has bias. Yeah. So I just want you to think about some of those things as we talk a little bit further around the trauma-informed care model. So there's our statistics. So 61% of adults have experienced at least one type of ACE. That's quite high, hey? 16% have experienced 4 or more ACEs. Again, it's a quite high statistic. And 72% of Australian children have been exposed to at least one ACE, with this rate higher in vulnerable populations. The risk factors, ACEs are more common in communities that experience poverty, discrimination and lack of access to healthcare. So we know it. We've done the research, we know it. So then if we look at these statistics, so if we look at an incarcerated relative, okay, nearly half, 47% of the approximate 1.25 million people in state prison are parents of a minor child. It's quite high. Substance use. In 2019, studies showed that 14.5% of parents across Australia report using illicit substances. And that's also, you know, pharmaceutical medication, but not for that use. Mental illness. 2020, 17% of parents with children aged 0 to 14 reported having mental health problems. DV. 2016, 86.6% of Australian adults reported violence. We know this is underreported. People don't routinely tell people that they're in DV. When I work with the police, I can see since COVID, DV situations have gone up. We're now in cases where we have so many unresourced jobs that we can't get to the mental health assessments of people because the police are tied up with DV situations. They're unresourced to manage it, and they're not trained to manage it. Divorce, 2020, proportion of divorce involved children under 18 was 49%. Again, since COVID, there's been studies done. We know the divorce rate has gone up since COVID. Since we're into lockdown and people having to spend more time together, the divorce rate is actually gone up. Neglect. At a statewide level, neglect is the most common form of maltreatment in New South Wales, Queensland, South Australia, ACT and Northern Territory. And abuse. The most recent Australian Bureau of Statistics shows 11% of women, that's 1.1 million, and 5% of men in Australia report have been sexually abused before the age of 15. And again, that will be underreported.
So if we look at multiple ACEs, to have multiple ACEs is associated with an increased risk factor for many health conditions. To sustain improvement in public health requires a shift in focus to include prevention of ACEs, resilience building and ACE-informed service provision. Extensive studies are now identifying the association between multiple ACEs and broad harm to life prospects, including education, mental illness, adverse personality presentations, employment, substance misuse, and poverty. So if we look at some examples, adults who have been exposed to 4 or more ACEs as a child were 10.3 times more likely to have injected drugs, 6 times more likely to have or caused unintended teen pregnancy, 2.5 times more likely to contract sexually transmitted infections, 15 times more likely to commit violence against another person, 20 times more likely to have been incarcerated, 4.6 times more likely to suffer from depression, and 12.2 times more likely to have attempted suicide.
Again, those rates are high. You know, we shouldn't accept those rates. You know, in health, it's there, we can see it. We need to be doing more. And I know it just doesn't come down to us. It's about policy changes. But people that make the policies need to know these rates. And as we said before, you're cutting 20 years off your life if you've experienced, 4 or more ACEs, 6 ACEs.
So if we look at the ACE effect on the brain development, so ACEs can have a profound effect on the brain development, particularly during crucial periods of growth, and can alter connectivity between parts of the brain. So you're looking at your amygdala, your prefrontal cortex, and your hippocampus. This can result in impaired emotional processing, difficulties with impulse control, memory, and poor stress regulation. So activation of the body's stress response system, so the HPA axis, leads to elevated levels of cortisol, which can impair brain development and increase anxiety, depression, and behavioural problems. So when we look at the amygdala, this is responsible for processing fear and emotional responses. This becomes hyperactive and enlarged in children exposed to ACEs, leading to heightened stress and emotional reactivity. The prefrontal cortex development governs decision-making, self-regulation, and impulse control. ACEs can impair the development of this region, leading to difficulties with executive functioning, including planning, attention, and self-control. In the hippocampus, those who have experienced high levels of adversity often have a smaller hippocampus, leading to memory issues and difficulties with emotional regulation.
So then if we look at toxic stress, so there is lots of research on stress, on the body. We get told it as clinicians, as shift workers, our life expectancy is decreased. If we're exposed to chronic, stress levels, it impacts our health. We know that. So if we look at the biological aspects of stress, it shows that the healthy development can be derailed by excessive or prolonged activation of stress response systems. Toxic stress can have damaging effects on learning, behaviour, and health across our lifespan. The toxic stress response can occur when a child experiences strong, frequent, and or prolonged adversity, such as physical or emotional abuse, chronic neglect, caregiver substance use or mental illness, exposure to violence, and or the accumulation of burden from the family economic hardship. And we know in COVID here, there was, again, I keep talking about COVID, but we know these stats have gone up since COVID. When toxic stress response occurs continually or is triggered by multiple sources, it can have that cumulative toll on the individual's physical and mental health for a lifetime. So we're not just talking a short period of time, it's for a lifetime. The more adverse experiences in childhood, the greater likelihood of developmental delays, later health problems, which we'll get to in a minute, including your heart disease, diabetes, substance abuse, and depression. And we know that research indicates that supportive, responsive relationships with caring adults as early in life as possible can prevent or reverse the damaging effects. I mean, this leads us into attachment theory, which people would have heard of, and that's a whole different talk. But if you want to look into attachment theory, it definitely links to ACEs.
So with hearing all of this, what do you think some of the chronic health conditions might be in someone who has experienced multiple adverse childhood experiences?
Heart disease, absolutely.
Anything else?
Diabetes, absolutely. Hypertension, yep. Developmental delays, absolutely. Obesity, yep, absolutely. Body dysmorphia, yep. So what's then the impact on health? If all of this causes an increase in health, what's the impact for you guys that work in general medicine? I would say it's quite high. Yeah?
What do you think some of the impacts you might see on individuals struggling with their mental health?
Yep. What was that one, sorry? Homelessness, yep. Low health literacy, absolutely. Yep, financial, hardship and insecurity, absolutely. Absolutely, emotional dysregulation, yep. And we'll come to that in a minute around management of that emotional dysregulation.
Yeah.
Yep. Yep. Yep.
Yep.
Wonderful. So this is again is just you can just have a quick look. We're not going to go through them all, but you've nominated most of them, yeah?
Okay.
So we'll just leave that slide up for a couple of minutes while you take all that in. So we've got our chronic health conditions, we've got our mental health, we've got our health risk behaviours, and we've got our social outcomes. Again, this is research-based.
So if we look at ACEs and resilience, resilience is the result of a dynamic set of interactions between a person's adverse experience and their own protective factors. The interaction is what determines the development pathway towards health and well-being or towards illness and dysfunction. These protective factors can include a person's own biological and developmental characteristics, but protective factors can also include characteristics of the family, community, systems that might mitigate the negative impact of ACEs.
So now this moves us into the trauma-informed care. Yeah, and you'll often hear, we bang on it all the time in mental health, you know, we need to look at trauma-informed care. So we're going to talk a little bit about what that actually looks like.
So trauma-informed care is the adaptation of trauma-informed care builds on the principles of patient-centred and recovery-orientated care while recognising the role that experience of trauma play in healthcare encounters and outcomes. So trauma-informed care is associated with a decrease in the use of seclusion, restraint, improved symptoms, shorter length of stay, better patient outcomes and cost benefits. Rather than being a specific set of rules, trauma-informed care or approaches is a process of organisational change which aims to create environments and relationships that promote recovery and prevent re-traumatisation.
So at Gold Coast Health, in knowing this, we have developed a lot of programs to try and work alongside this. So we have our co-responders. We have 3 of us now on an afternoon shift with the ambulance, going out and assessing mental health patients in the community. The aim is about ED avoidance. We don't need to bring everybody in. If we do need to bring them in, it's about decreasing that length of stay and making sure that we're performing the trauma-informed care. We're working with that patient, yeah? We also have our crisis stabilisation unit, which is a unit that we developed, which is staffed by people with lived experience alongside clinical staff. So it's really trauma-friendly, really. People understand what trauma-informed care is there. We actively look at who's coming in, so we're not putting people that may have significant trauma and then we bring in an aggressive psychotic person that may trigger that person. So it's definitely weighed up who comes in. So people often say, why can't we just fill those seats? Well, we're looking at the patients in there. We're not going to re-traumatise somebody. Yeah? But our aim is to look at our CSU rather than emergency department. We have our watch house nurses. So I think the first speaker spoke about police. We have nurses at the ED place in the watch house specifically to try and manage our patients, you know, in short-term custody. We also have our nurse navigators that we've pulled on board, again trying to look at how we can work with our patients rather than bringing them in and re-traumatising. So lots of the work when we're co-responders, we actually know a lot of our frequent callers. So it might be a phone call on the way and we'll start treatment on the way. An example might be, and we might know somebody, can you go to the freezer, grab the ice? I want you to hold the ice. hold the ice, rather than cut yourself, I want you to hold that ice while you're talking to me. So we're calming them down the whole way. I'll be there soon. I'm 8 minutes away. So we're working with that person from the initial onset that we're responding to them. Yeah, we're working with them around the trauma. We know them very well. Those ones that we don't know, and if they have no SIMA history, which is their mental health history, and we would have a good read, we have more access than just our normal Bravo crews around what the situation is. So we're trying to sum up what we're walking into. So we have some idea. I call it dipping my toes in. So you don't rush in, I dip my toes in. Am I going to go further into that water, or do I need to pull back and try a different approach?
So why it matters, trauma-informed care shifts the focus away from what's wrong with you to what is happening to you. It's guided on the 4 assumptions. So realization about trauma and how it can affect individuals and groups, recognize the signs of trauma, and a system which can respond to trauma and resist re-traumatization. So there are 6 core principles of trauma-informed practice. If you want to go into them, Kim.
Okay. So first we have our safety. So we're prioritising our physical and psychological safety. As I said, if we can ring them, if we can calm them down, if we can start treatment as we're getting to them, then that is our first port of call. Everyone has a different definition of safety, which is usually to connect with one's identity, history and personal experience. I have an example of one person that frequently rings. She'll never answer the phone, but I can text. She knows she can't ring that phone, but I'll say, "It's Kim, I'm trying to call, can you please answer?" Oh, we've got 10 minutes left. We're given a 10-minute warning. Okay, so I'll miss all the scenarios. It's about creating a space where patients feel emotionally connected and comfortable to share or engage in that conversation. Then we have the trustworthiness and transparency. So the organisation operates and decisions are conducted with transparency and the goal of building and maintaining trust, and that's important. Yep. A person who's got trauma, we need to build that trust. Peer support and mutual self-help, which is it's vital to the organisation and service delivering the approach. It's understood as a key vehicle for building that trust, establishing safety and empowerment. We have the collaboration, which is recognising that healing happens in relationships and in a way that's sharing power and decision-making, and acknowledging that everyone has a role to play in trauma-informed approach. One does not have to be a therapist to be therapeutic, and that's important. We're all humans. Lots of this is it's not science. It's being a decent human being. What does that person need? We all know when we're upset, what do we need? So if we can think about that when we're speaking to a patient. Empowerment and choice. So it's strengthening the staff, patients and families' experience of choice, and recognise that each person's experience is unique, requires an individual approach, and build on what the patient has to offer, rather than responding to those perceived deficits. So definitely when we talk about recovery-focused care, it's working with the patient. It's not what we think. We work with the patient. What do you need? What helps you? It's their recovery. You can give them all the strategies on the sun, but if they're not part of it, they're not going to follow through with that. And it's that cultural and historical and gender issues. So moving past the cultural stereotypes and biases and offering that culturally responsive service.
So looking at therapeutic relationships. In trauma-informed care, the therapeutic relationship is the single most important aspect and indicator for successful treatment and healing. Robust and therapeutic relationships engender trust, collaboration, mutuality, empowerment, and support voice and choice.
We have a laugh about that word because when we were running through it today, I think we called it mutant, but you've done well, Talia.
So Carl Rogers developed person-centered therapy. This is an efficient model of counselling and therapy. He emphasised the role of therapeutic alliance and the 3 primary components. So he had empathy, understanding the client's perspective, congruence, the counsellor is genuine, open and real, and unconditional positive regard, providing that non-judgmental acceptance and approach.
So this is a quote by Carl Rogers, which I actually like. So we think we listen, but very rarely do we listen with real understanding, true empathy. Yet listening of this very special kind is one of the most potent forces for change that I know.
So when we look at our benefits of trauma-informed care, so for the patient, it looks at improved health outcomes, increased trust and engagement with treatment and services, reduction in re-traumatisation and mental health crises. For healthcare providers, it looks at enhanced therapeutic relationships, reduced staff burnout and improved morale, effective care being delivered. Some of the importance of trauma-informed practice in the ED: it's a high stressful environment. It's often fast-paced and can be overwhelming and overstimulating for patients. Often patients in the emergency department have experienced recent traumatic events and are very vulnerable. There's the potential for re-traumatisation. We often have invasive procedures, lack of privacy, and unintentional insensitivity from healthcare staff.
I think we have an example, just to throw an example out there. So there was a recent, maybe you can talk about it more, Talia, the lady.
So I had a consumer recently, and the handover in the morning was that they had been intoxicated and aggressive and required restraint and IM sedation. Reading through the notes, it was made very, very clear that this woman had experienced recent sexual assault and a loss of pregnancy. She was put in what we call our mental health pod, surrounded by 4 manic males who were quite sexualised in their behaviour. So she became quite dysregulated, asking to leave, wanting to go outside, not wanting to be stuck in there. That was perceived as aggressive. So she was then held down and given an injection. When I spoke to her in the morning, I had asked the security to leave and provide us some privacy so we could have a conversation around what was happening, and moved her promptly out of that area where she felt somewhere safe and we could continue our assessment. Then providing education to the staff around the inappropriateness of what had occurred, which could have been prevented, but yeah, it's just important to remember that, you know, sometimes people's backstory is really important to acknowledge prior to moving them to an area.
And it was interesting to note that backstory was documented by one of the ED registrars, but the nursing staff on duty didn't read back in the documentation, and unfortunately we re-traumatised that woman quite significantly.
So when we look at implementing trauma-informed care in the emergency department, so it requires regular training for all staff working in the department. So not just nursing staff or doctors, you're looking at your admin, you're looking at your wardies, you're looking at all house. Screening for trauma, however, ample training should precede screening, and if risk is identified, appropriate care and pathways should be provided. Engaging referral sources and partnering organisations. Becoming trauma-informed requires a steady support from senior leaders, and creating a plan that empowers the workforce to be part of that transformation process can help generate buy-in throughout the organisation. And when we look at our environmental modifications, so privacy considerations, curtains, low stimuli environments, you know, looking at our lighting, noise, colours, these things are hard to change, but even just providing that sense of, you know, privacy to have that discussion with an individual, it means a lot.
There's another example. We have a well-known autistic boy, severely autistic. We've got 5 minutes left. Thanks, Quentin. Now, you know, I brought him in one time. He also has a significant trauma history. So I pulled him off a bridge. He had one leg over and he was about to jump, so I pulled him off the bridge. His parents were then saying they didn't want him home. So we had to take him into ED. That's not an environment we like to take this boy. He also has a periods of times when he becomes so distressed that he becomes catatonic. So when we got to the ED, he collapsed on me, fell on the floor, and just is unable to communicate. In knowing him, he hears everything you say. He hears everything that's going on around him. So he will give 1 blink for yes, 2 blinks for no, 3 blinks for I don't know. So that's written in his mental health notes. And the ED, it was at Robina, which my colleague is there. So they were swiftly able to, with me saying, this is a boy that's extremely traumatised. So we took him off the floor at the ambulance triage, and we created a safe environment for him where we could create that privacy to have that conversation with him.
And often when interacting with consumers or patients, it can be as simple as clarifying names, pronunciation, pronouns, introducing yourself, your role, what you're there for, what the purpose of this interaction is, positioning yourself when safe to do so at their level to have a conversation, who likes to be spoken at or spoken when someone's standing over the top of you. Being aware of your reactions to that person, so that can be non-verbal as well. So being aware what your face is doing or what your arms are doing, or if you're giggling with other nurses at the nursing station, just be mindful of that. And calm and respectful language. We want to avoid stigmatization and be clear in describing procedures and at their health literacy as well, you know. We want to make sure they're understanding, they can provide informed consent, they know what's happening, so we can incorporate shared decision making. So does anyone else have anything to throw out of what they might already be doing to when they're interacting with individuals who may have experienced trauma? Could be as simple as offering a cup of coffee or a sandwich or a glass of water.
And I often say to people, which is an activity I do when I do a 2-day workshop on this, you know, it's about reflecting when you've been distressed or you've been angry, what helps and what doesn't help. You know, we know what doesn't help us. So 9 times out of 10, it's not going to help that person either. And I know we get busy and I know it's really demanding, but sometimes just to take that step back and look at, you know, what could we do differently?
And looking at our assessment and treatment approaches, so presume everybody who presents to the service has been exposed to a traumatic experience, understanding that many will have multiple events, both in childhood and adulthood, and recognise that coercive interventions cause traumatisation and re-traumatisation and should be avoided where possible. And look at affect regulation. Self-soothing, or the capacity to tolerate or regulate emotions, is central to well-being. Complex trauma disrupts this. So we need to look at some options which can be utilised. They could include co-regulation, sensory tools, mindfulness, distress tolerance techniques, and modelling affect regulation.
And I can give a personal example, which I will write a paper one day around just a personal experience. So this year I've had lots of health complaints. There was lots of procedures, lots of inpatient admissions, lots of discussions with consultants. So we opted for an operation. It was very clear it was 1 in 5 chance of distinctive complications which could involve death. Each consultant I spoke to, I had to involve my family. I was told my children had to give informed consent. Even when I said, look, I've got capacity, you know, it's about quality of life. Even to the night before I went in for that surgery, the consultant rang to say, are you on the floor? And I said, no, I'm out in the ambulance. I had him on speakerphone, and again, I got the whole drill. This could involve you dying. Are you willing to make that decision? To the point that the AMBO I was working with said after the phone call, I'm concerned, I don't think you should have this operation. So I go in for the operation, the consultant comes in, and I said, it was an ERCP and sphincterectomy. I said, did you touch my pancreas? He told me no. So I thought, great, because the risk was if you touch my pancreas, you will cause acute pancreatitis, which could involve death. They kept me overnight, but they put me in the transit lounge. So I'm not sure if people are aware, transit lounge, not the right place to put me. So when I started to vomit extremely badly, the nurses had no idea. Nobody had given handover. It was me that had to say, I'm at risk of complications. I'm at risk from dying. Their response was, you're too acute for us. We need to find you a bed. The only bed they could find me was on maternity. So up I went to maternity. By this stage, I was completely dehydrated. They couldn't get an IV bung in at all. So I was laying on the dirty floor under the shower. It was the only way I could get relief. Had 3 doctors come and try and put that bung in. When I said the pain is so bad, it's in my back, I was told this is not acute pancreatitis. I'm a mental health nurse. I know pain in your back is acute pancreatitis. I was told, try not to vomit so profusely. You've got 2 stents in place. You will perforate them. Nobody rang my next of kin. So my children had been exposed to this whole sense of that I could die. So they're at home going, we haven't heard from mum at all. There was a lovely nurse and she did sit with me and she was a godsend. When I said, I'm scared, I'm dying. And did I tell you the nurse came in and said, did I say that? Look at your stomach. Does it always look like this? So then I looked at my stomach and thought, oh my God, I am actually going to die in the hospital I work in. It was that distended. They eventually found me a bed on a ward. I was treated, how I felt, was like I was an alcoholic. I was a drug seeker. It was over the weekend. Monday, when they found out I was a CNC in the hospital, my whole treatment changed. I had doctors coming in saying, we need to stop the opiates. You're abusing the opiates. Like, I was in hospital for 8 days, couldn't eat for 11 days. So then we were met with refeeding. My vision on that is trauma is if you had have treated me like a patient rather than being treated like I could be an alcoholic. Even if an alcoholic has acute pancreatitis, they should be treated with respect. I was so sick for 3 days I couldn't pick up my phone to tell my family I was okay. On the Monday, I had a lovely registrar who came in and said, we'll fix it. It's okay, Kim. It's awful how you've been treated, and this will stop now. That was traumatising. To go back in and have 2 stents removed after that, I was petrified the same thing would happen. So my story on that is about if we don't give good handover, how do people know what the risks are? It shouldn't be up to the patient. You know, what if I had no health literacy? You know? Oh, we're done. Hang on.
About that.
So just a bit of reflection. Was this helpful? Did it make you think about the impact on our health issues? Yeah. Will it make us think more about how we treat people in the future, do you think? And the sad thing is I think it needs to be up to management to make these changes. We need to do more education. You know, we need to run workshops on how we manage this. You know, we know the statistics are huge. They're massive, 4,000 to 5,000%. But yet we're not pushing it from a health policy perspective. And again, I think it relates down to, again, my thing around overshadowing for mental health. And this is just a quote I want to end on. And I often think of this quote before I go into every patient. So I'm not perfect, you know, we all have our bad days, but before each patient, I try to clear my head from the one before, and I try to take that moment to remember humanity. There's no experience that this man has that I cannot share with him. There's no fear that I cannot understand, no suffering that I cannot care about, because I too am human. No matter how deep his wound, he does not need to be ashamed in front of me. I too am vulnerable, and because of this, I'm enough. Whatever his story, he no longer needs to be alone.
Okay. Yeah. Conclusion, summary.
All right, let's hear it for Kim and Talia. We might try and get you a glass of water up there, Kim. Oh, you've got one. Fantastic.
I've got a post-viral cough, apparently.
Well, thank you both very much. And let's have a round of applause for all our presenters this week.
We do have handouts too, Clinton.
Yes, so we have a handout that's just at the back of the room. Unfortunately, we did have to rush Kim and Talia there a bit. There was a lot of information there. So Patty's just put a handout at the back. Please feel free to grab one on the way home. Could be some good reading for the plane ride for those that have to head back soon. That's it. That's the conference. Unfortunately, as Kim mentioned, Dylan's rather unwell in bed at the moment after, I don't know, probably brushing his teeth with the water or something like that. But on behalf of us, we would just like to say a huge thanks to absolutely everyone for coming to this conference. Really excitingly, we donate part of the proceeds from every ticket to a charity each year. This charity this year was Full Stop Australia, which do a great job in support, advocacy and education for family and domestic violence. And thanks to all your help, and also with Everest Wealth, the guys that presented on Tuesday for the workshop, we've now raised $10,000 for this year. So let's have a big round of applause to all you guys. So if you thought the traffic was bad earlier in the week, I've just got some photos that makes it look like it was free flowing. So just a reminder that tonight to get to Damaria, it may take around sort of 20 minutes from the Trans Resort. For those going on the shuttle organised by Locum Life, feel free to bring drinks on board or anything else there so you can hydrate. Otherwise, There's no formalities tonight. It's really just about enjoying yourselves. So from 7:30 to 9:30, the drinks will be flowing. There'll be some pizzas handed out. For dietary requirements, vegan, vegetarians, and lactose intolerance are catered for with the pizza. For the gluten-free, there will be a separate table with food on there. So just keep an eye out for that. Not quite sure where that will be in the building, but if you're gluten-free and you're hungry, come see myself and I'll hopefully be able to point it out to you, or just have a bit of a look around. Otherwise, we really just want to thank you all. We're super excited to be able to run these events. As I mentioned earlier in the week, our background is paramedics, not conference organisers. So tomorrow you will have an email that goes out. It has a feedback form on it. If you do have a couple of minutes to spare, we'd love to hear your feedback because we really are about, I guess, improving these events and also opening up more destinations as we move on. So thanks to all of you. Look forward to having a drink with you all tonight. Enjoy.